You're listening to Gender, a Wider Lens. I'm Stella O'Malley, a psychotherapist in Ireland.
And I'm Sasha Ayad, an adolescent therapist in the United States.
In this podcast, we'll explore gender from a psychological depth perspective.
We're curious about the concept of gender and how it is unfolding in the wider culture.
Join us as we look at gender through a wider lens.
Dr. William Malone is a board-certified endocrinologist. He's a graduate of Stanford University with a BA in Human Biology and New York University Medical School. He completed residency in internal medicine and a fellowship in endocrinology, diabetes, and metabolism at the Los Angeles County University of Southern California Medical Center. He's been in clinical practice since 2008 and holds an appointment as an assistant clinical professor of endocrinology from the Idaho College of Osteopathic Medicine. Here's our conversation with Will.
Hi there, Stella here, and myself and Sasha are very excited that we've got the one and only Will Malone here to speak to us, the endocrinologist that first came to my attention a couple of years ago. And I'm so interested in what Will has to say, about everything. It's not just about puberty blockers, but all sorts of things to do with hormones. Will seems to have a very incisive and sharp analysis of the situation. So I'm really looking forward to this following hour.
Welcome, Will.
I'm glad to be here. Thank you.
So we were wondering if you could perhaps just start us out with a little bit of background of how this topic of hormonal intervention in children, how did that come onto your radar? Maybe you could tell us a bit about how you got interested in this.
So I would say two things simultaneously started to happen, probably in 2017. So the first thing was I started to get calls from local primary care doctors, and they were describing essentially a cohort, basically a sudden appearance of young adolescent females who were declaring themselves to be transgender. And they were calling my office and saying, "Hey, this is a totally new thing for us. We've not seen this before. What's going on here? Can you help us out?" And essentially, what they were describing was typically in kind of small clusters of adolescent females, girls, that one of a friend group would declare themselves as transgender, and then essentially others in that friend group as well. And so the primary docs started to call my office and say, "We're seeing something that we haven't seen before." They were obviously aware of the cultural shift or things that were occurring as well. But then they started to see this in their own practice, and they were unprepared and started to reach out.
Sorry, can I ask, what were they asking for? What did they want your help with?
Yeah, so they really they wanted to know what to do. So they had a patient in front of them of varying degrees of distress, and essentially some were stating, I'm non-binary, or I'm transgender, whatever the descriptor was. Varying degrees of distress. Some requesting hormones, some not. But they essentially were caught off guard by the presentation of this, of these young women to their offices, and so they were basically asking, "What do I do?"
And can I ask, what was your experience until then of transitioning people, or transitioning younger people or older people, anybody?
Yeah, so as an endocrinologist, and I consider myself, I'm an adolescent and adult endocrinologist. Most of my patients are adults, but some adolescents. But as part of that training, and in the field of endocrinology, this phenomenon of gender dysphoria has been known essentially, quote unquote, forever, at least from my standpoint, because I've been in practice now for about 15 years or so, but certainly going back to the 50s in the medical literature. And so this is not a completely unknown entity for endocrinologists. It wasn't a big part of our training, but we certainly knew, going back a long time, that there were a small number of children who developed gender dysphoria. Most would resolve with puberty, but some would have persistent and severe gender dysphoria through puberty and then into young adulthood, and they would seek out cross-sex hormones and surgeries. And there was, kind of the way it was is, well, there was an endocrinologist. Usually this was in larger cities, and a surgeon who would prescribe hormones and then potentially surgeries for patients who were seeking them. We knew that there was not a good evidence base to support these interventions, even back then, and even now. This was kind of I don't know how to. It was something that occurred outside of mainstream practice. I guess I would put it. We knew that in terms of the folks who had gender dysphoria and who were looking for these hormones and surgeries, it was the traditional understanding that some were same-sex attracted men who traditionally came from backgrounds where homosexuality was not accepted. These folks typically came from African American or Latino backgrounds, and there was a high rate of prostitution in this group, and a lot of risk in terms of infectious disease and such. And the other group were, we didn't really know this term, but basically men with what we now know is autogynephilia. So essentially these are heterosexual men who are sexually aroused by the thought of themselves as women. And so that was our traditional understanding of gender dysphoria. Those were the two predominant groups of folks who were presenting. And so that's been going on for a long time. What was new, and it really kind of hit my community here in the so it was 2015, 16, and 17, was a shift from predominantly males to females, and not the traditional childhood onset, but more of a later, even after the onset of puberty, onset of gender dysphoria, or this proclamation of a transgender identification. Whether or not we can even consider this new cohort as having gender dysphoria, and I'm sure we can kind of debate that.
I want to emphasize that, like Harry Benjamin, who started WPATH, and he called it the Harry Benjamin International Association of Gender Dysphoria, he was an endocrinologist. And so it's really like the endocrinologists are center to this. The surgeons, the endocrinologists, and the psychologists are the main three who bring this about as a team. And so I think people often forget just how important the endocrinologist is in this. And then Norman Spack also is an endocrinologist, and he's the guy, for anybody who doesn't know, he's an American pediatric endocrinologist who was, as he says himself, and I'm quoting, salivating at the idea of puberty blockers when he first heard about them, because he was so excited about the vista that it opened up, that he could block a puberty and maybe simulate another kind of chemical puberty of the opposite sex. And this is very much a case of what your science can do, I feel, with endocrinology, and same with surgery. It opens up all sorts of concepts about what you can do. And I'd imagine, I'm asking you a very long intro there, Will, but I'd imagine there's something very alluring about testing your field to the limits, that I'd imagine there's endocrinologists out there who just want to know, well, how far can we go with endocrinology? Where does it bring us?
Yeah, it's a really interesting take on it. So this kind of links to the second thing that started happening, and then I'll try to get back to what you just said. So you're right. So the endocrinologists are key because we're the prescribers of these hormones, these powerful drugs. And we do this as part of our routine practice. And so we have with other medical conditions, I mean, this essentially our job is to interrogate abnormalities in hormones. And then if levels are too high, we bring them back to normal. If they're too low, we bring them up to normal, essentially trying to reestablish equilibrium. So the second thing that started to occur linked to this was around the same time that I was getting phone calls from primary care docs saying, "Hey, what's going on here with this new presentation of gender dysphoria, this adolescent onset?" The second thing was in 2017, the Endocrine Society basically they put out a position statement for to guide endocrinologists. And the Endocrine Society is a massive organization. Their national meetings pre-COVID would have 4,000 or 5,000 attendees from all over the world, and they put out guidelines. Highly respected organization. They put out guidelines to guide endocrinologists. And so 2017, they put out guidelines, and I was at the meeting. And they essentially, in stark contrast to my previous experiences, they rolled out a set of guidelines for gender dysphoric adolescents and children that had really no evidence base, and essentially said that, okay, your job as endocrinologist now is to medically affirm children, adolescents with puberty blockers and cross-sex hormones should that patient, or should the mental health professional taking care of that patient recommend them. And so this was shocking to myself and many others who were listening. And the reason it was shocking is that puberty blockers, if you start puberty blockers, and these recommendations essentially said, okay, at Tanner stage 2, which is early puberty, it's just after puberty starts. If you start puberty blockers at Tanner stage 2, and then you follow those with cross-sex hormones, so for a young girl, it would be puberty blockers followed by testosterone. There's an almost certainty that she'll be infertile or sterile. And the same for boys put on this pathway. So essentially, the Endocrine Society came out with guidelines recommending a treatment protocol that results in addition to the other irreversible changes that come with cross-sex hormones, and the complete lack of data showing that puberty blockers are in fact reversible, and that's a debatable statement for normal puberty. They essentially put out these guidelines. And said your job is to affirm. And so I started to look in close detail.
What did you think when you saw it, when you saw the guidelines, when you first saw them?
Well, I thought to myself, well, my previous experiences with the Endocrine Society have been very good. And so there must be some landmark study that's occurred. Some massive change in the landscape that I missed, okay, somehow, which would be unlikely because I stay up to date and I'm on the email list and all sorts of things, right? So I'm thinking to myself, boy, there must be some piece of evidence in this document that is stunning to basically shift the landscape to recommend that mental health support and psychological support and psychotherapy are out and affirmation is in. There must be some stunning piece of evidence inside this document. And so I opened the document and it's not there. There is no stunning piece of evidence. These recommendations are based off of essentially for puberty blockers and cross-sex hormones, a single uncontrolled study out of the Netherlands. And, when you look into that study in some more detail, you see that it's So there, in the scientific world, in the academic world, there are ways to rate the quality of evidence, and obviously something that has more quality evidence, you take more seriously, and you think, well, if this is high quality evidence, if I do something following this high quality evidence, if I intervene, the chance that I'll make a mistake is low. But this evidence was low quality evidence because there's no control group. It was a small group. There were a lot of confounding factors, and so it's understood in academic medicine and in medicine in general. If you intervene based on low quality evidence, if you make a clinical decision based on low quality evidence, there's a decent or high probability that you'll be wrong.
Wow.
And so in those situations, and so the question really becomes, and this group that I've helped form is essentially come to this conclusion, which is that the quality of evidence to support interventions, medical interventions for gender dysphoria, meaning puberty blockers and cross-sex hormones and surgeries, is so low that essentially these should still be considered experimental therapies, meaning they have not been proven to work, and so they need more investigation. They shouldn't be accessible to the general public outside of controlled trials, meaning these trials are designed in such a way that you can actually determine whether or not they provide psychological benefit for the people who are participating in them. And those types of trials have not been done yet. And so in the absence of those, these interventions are still experimental. Sorry. So Stella, to circle back a long way to get back to your point, which is essentially, yes, in a way, and in a strictly scientific definition, endocrinologists who are prescribing puberty blockers and cross-sex hormones to adolescents outside of clinical trials are engaged in experimental medicine. They are experimenting essentially by the classic definition. This is not even an opinion. This is just a definition. If you're engaged in these activities when there's not high quality evidence to support them, you're essentially engaged in experimental medicine. And that's what you start to see. What you've described as, well, let's see what we can do. It turns into a very chaotic scenario, and the consequence of that is that people will be harmed, and that's what we're seeing.
Gosh, it's really incredible to try and synthesize all of what you're saying. First of all, we're recording this in December of the year 2020, and the UK has just ruled in a very landmark judicial review that prescribing puberty blockers to minors is something they cannot consent to. And in the ruling, they described, after a lengthy investigation, that this is experimental. So everything you're saying and everything that you've been saying, and we'll talk about SEGM, which is the organization that we're talking about here, has been corroborated by this really extensive review in the UK. Yeah. And there's just a couple things that stand out to me that are really fascinating and gets me curious if there's any precedent here in medicine. But first of all, you describe that gender dysphoric people prior to the mid-2010s were treated in kind of niche clinics that were outside of what the mainstream medical community was comfortable doing. Yes. That's how I interpreted it.
Exactly.
So when the Endocrine Society put out that statement advising mainstream endocrinologists, to start using procedures that were even more experimental than what the niche physicians were using, that seems like a very remarkable, rushed direction to go in.
Yes.
And I was struck too by the way you initially assumed you could defer to the authority of the Endocrine Society because they're such a reputable
key point
organization. Yep. And so you happen to say, well, there must be some data in here that justifies this seemingly radical decision. Let me take a look. I wonder what's your pulse on this, do you think a lot of other endocrinologists took the time to look into it in the way you did, or did other people just assume, well, it must be good reason, and just move on and look away? Because obviously you became really, really curious about this, and you've now spent a lot of your energy personally trying to research the data and understand this. But do you think that happened to a lot of other endocrinologists when they put out that position statement?
Yeah, I can answer that partially with a little bit of speculation and also just my own, interactions with my colleagues. So it was really fascinating because, at the same conference where they rolled out these recommendations that had low quality evidence, and furthermore, when you looked, it states right in the document that these interventions, the goal of the interventions was to favor cosmetic changes in appearance over potential harms from these interventions, and the harms are significant, right? We're talking about infertility, and a woman who takes testosterone, her voice will drop significantly, within a few months of initiation. There are facial changes, hair changes, skin changes, all sorts of stuff. So increased risk of heart disease long term. I mean, the risks are significant. So at the same conference, it was interesting to see these two things happen side by side. So, and this would be more typical. There were hour-long discussions in front of a large audience where you would have two of the world's experts on a particular topic, and there might be 10x. So people at the top of their field in this niche area of endocrinology. So let's say it's adrenal tumors or type 2 diabetes, and so over the course of an hour, you would have a discussion where one expert would present, okay, here's why you all out there should start prescribing this new diabetes medication. And here's my, review of the literature, and here's my impression of this, and et cetera, et cetera. And then on the flip side, you'd have somebody else saying, no, you all should not start prescribing this new medication because it's too expensive and it's not been tested enough, and basically make a counterpoint argument. And this would go on, with slides over the course of an hour. Really just brilliant stuff.
Yeah.
And how you would expect, how as we as clinicians expect these conferences to be run. And I suppose on the outside, how lay folks would expect medical professionals to be carrying out their business of figuring out what the best interventions for suffering people are. And so at the same conference, you have these point-counterpoint discussions of, no, you should not operate on adrenal tumors. You should intervene with medical therapy, and here's why, et cetera, back and forth. Really brilliant things, discussions. And in the case of gender dysphoria, there was none of that. There was no discussion at all. It was difficult even to submit questions after they presented the guidelines. It was done under an atmosphere of, this is how it's going to be, and if you ask questions, you're a bigot. It was in stark contrast to the rest of how that organization operates.
Who's the they? I mean, you said they would say you're a bigot. Was it the presenters?
This is kind of, no one said that. This is the impression that's given, essentially.
Fair
is
enough,
that
yes.
Is that this is how it's going to be, and if you ask questions, there's probably something wrong with you. You need to take a look at yourself. So the atmosphere was completely different than the openness of the discussions that occur with other. As they should occur. And so that was a major red flag. And it was a red flag.
Setting this atmosphere, Will, was it the presenters who were talking about the interventions people should be performing on gender for kids?
Yeah.
Okay.
Yes. And so it's the tone, and also, well, this is just how it is. And, this is the spectrum of gender and sex now. Mm. And so essentially in contrast to, and so the Endocrine Society is allowing these types of presentations to occur. So in contrast to okay, here's what the literature shows. And then based on the literature, here are some recommendations. It was, okay, now these are the definitions and this is decided. And we're not going to discuss what it means to be gender dysphoric or transgender or non-binary. We've decided these definitions, and we're now going to dictate this information to you. And so the tone was completely different. It was no longer a scientific debate. It was, this is how it is, and this is how it's going to be. And so that was very startling.
Did you, may I ask, that conference, did you discuss with your colleagues, wow, this is a new way of doing things. This is a new approach. It seems very dogmatic.
At that point in time, certainly yes, it was. Have you looked at this? There's no evidence to support these interventions. This is low quality evidence, and this gets into the kind of the interaction between culture and medicine. There's no cultural space to ask questions about this topic, and so that cultural atmosphere had infiltrated the medical conference. And so there was, self-censorship and very difficult to get anybody to speak honestly. But as soon as you ask them about, this diabetes medication or whatever it is, oh, no, you shouldn't be doing that. Have you seen this? Like, blah, blah, blah. But when you ask about, hey, have you seen, there's not a lot of quality evidence here. Don't you think, psychotherapy or, some other form of psychological support could be beneficial? Oh, maybe, I don't know. I haven't, avoidance, essentially, you know what I'm talking about. No one wants to take a position.
I would like to jump in here. I believe very strongly that people think it's way beyond my understanding. I don't know why somebody might want to transition, so I'm not going to touch it. I'm just going to follow the rules because I don't get it at all. So it's almost comes from, wouldn't quite say transphobic, but certainly trans ununderstanding. Just kind of, don't get it, give me the instructions because I'm too afraid to have an opinion on it.
Yeah, so the medical professionals, if you have, so my colleagues, so if you have a relationship with these folks and they feel that they can be more honest, they'll be honest and they'll say, yeah, you're right, there's no evidence here. No, this doesn't make any sense. This is in stark contrast to how other areas of medicine evolve. There's been suppression of debate, but in a stressful, medicine there's a lot of stressors, and days are busy, and so routine clinicians, not routine. What I mean is, in the day of a routine practice, clinicians are going to often choose the path of least resistance, which is either avoidance or just simply referral out to someone who's willing to see these patients, and that oftentimes it means an affirming counselor or a gender clinic where we know that once a kid, based on the data that we do have, once a kid gets started on puberty blockers, essentially they're going to be the chance of them going on to cross-sex hormones. Puberty halts no surprise, it does what a puberty blocker does. It halts the development, physical, psychosocial development of an individual. And so the chance of them coming to a stable gender identity consistent with their biological sex is likely not going to happen. And so all these kids go on to cross-sex hormones, 98, 99, 100%. And that was another finding, right, of this recent UK court case, that essentially puberty blockers have to be considered. And the evidence supports this as the first step in sequential interventions.
I want to ask a question that comes up for me. You talked about how, behind closed doors with colleagues that have, close rapport, people can acknowledge with one another that there's really no good evidence for these interventions. I'm curious about how does this entire dynamic lend itself to, what type of endocrinologist actually pursues gender medicine specifically? I wonder if this whole thing has created a kind of funnel where endocrinologists who want to go into this area of medicine have already either dismissed the fact that all the evidence is really low quality, or perhaps are willing to disregard the evidence. Like, what's your sense about that? Like, what endocrinologist pursues making this a full-time career of puberty blockade and cross-sex hormones, knowing that there's so little good evidence and no controlled studies?
Yeah, that's a good question, and I think it gets into, especially in the United States, where we have a profit-driven healthcare system, and so one of the legitimate critiques of what's occurred culturally is, and this is known in other areas of medicine as well, is that if you create a new product, essentially, if there's demand for something, you offer it. It fuels itself. It begins this cycle on itself. So there's more demand. And then there's more clinics opening, et cetera. So in 2010, I think there were about 6 gender clinics in the United States, and now there are more than 50, and I think even close to 70 at last count.
I think there's 65 last time I checked.
Yeah.
Mm-hmm.
So, and this doesn't even count the, clinics who wouldn't consider themselves to be quote unquote gender clinics. So they're not going to be kind of traditional referral centers. This will be a Planned Parenthood or another small community clinic, or even like a clinic at a college or a university. Where many of these places are operating under informed consent models, where essentially you walk in the door. And so this would be for folks who are 18 or older, but you don't have to undergo any psychological evaluation, and if you do, it's essentially with a counselor who advertises themselves as lowering the threshold, as making it easy, essentially, to get the letter, quote unquote, so that you can get cross-sex hormones. And so, yeah, there's definitely so the endocrinologists who are not interested in prescribing cross-sex hormones and puberty blockers because there's no evidence to show that long-term psychological improvements occur, they're basically just going to be completely outside of all this occurring. And then there will be endocrinologists who are just going to follow the guidelines because that's what the guidelines state, and they'll feel comfortable doing that. And then there are others who will look in more depth and realize there's a big problem. So there's definitely market-driven forces that have, I think that's the best way to answer that, that have resulted in an explosion of clinics offering these interventions that are, as I mentioned before, these are considered experimental.
It's fascinating when you hear when kind of demand creates supply, and then supply creates further demand, and endocrinologists are suddenly in the center of this massive phenomenon that they never really had to kind of think about very deeply before, and they've been kind of landed into it right in the middle. So I'm very keen to hear about what you have to say about puberty and when it's blocked and all that. But before that, perhaps if you could tell us how we all 3 of us met in SEGM and how that came about for you.
Yeah. So SEGM, the Society for Evidence-Based Gender Medicine, essentially it kind of organically came together 2018 after these experiences that I started to have, and I realized that others were having similar experiences, and were concerned that the general public and also clinicians were not aware of really what had gone on to bring us to the point that we were, that there was a lack of evidence to support these interventions, that there were significant risks associated with them, and there was no place for folks who were questioning either lay people or clinicians who are questioning this rush to affirmation to educate themselves and to make contact with others who had similar concerns. And so that's how the organization got put together. And very quickly, 2 or 3 people, and they know 2 or 3 people who know 2 or 3 people, and before you know it, we have over 100 clinicians who have basically come together to share stories and information, and to kind of work together towards that purpose of educating the public and other clinicians through scientific writings and through our website to raise awareness so that folks can make good decisions, or at least know that there's not good information out there when they're attempting to make good decisions for kids, young adults who are struggling with gender dysphoria. So that's how we all got connected together, and how that organization got started.
Well, what's important to me is that by the time SEGM started to come together, I think there were already several really great blogs for parents, for example, or some young people who had adverse experiences taking, gender interventions.
Mm-hmm.
We're talking about detransition, but there wasn't really a place for medical professionals, mental health professionals to organize and say, wait a minute, there is not a medical consensus here. And it's kind of interesting, right? Because there's been this, kind of institutional capture where all of these large medical and psychiatric organizations have kind of gotten behind this gender medicine. And I'm starting to see with the UK ruling, at least in Europe and other countries around the world, these large organizations, even these gender clinics, are starting to pump the brakes. And I'm hoping that the US will catch up. But perhaps we can talk a little bit about the UK ruling and what it is that they found regarding puberty blockers, and how do you think this will impact medical professionals who are curious about what's going on? So let's talk a bit about the UK ruling from an endocrinology point of view.
Yeah, sure. So I mean, the conclusion that they came to was, as you said, an accurate representation of where we stand, which is that these interventions are experimental. That young people can't understand the implications of initiating puberty blockers, cross-sex hormones, and surgeries. Let's see. And that makes sense, based on our understanding of brain development, that, kind of cognitive maturity does not occur until the mid-20s. And this is something else that it really is drilled into physicians' brains right from the start. So, for example, it's very unusual to send a woman for a hysterectomy that would render her sterile before the age of 25, even if she wants to, because there's a general understanding that minds change before the age of cognitive maturity, and especially if an individual has an autism spectrum condition or some other situation that might delay brain maturity, that age of maturity might even be later. So basically, the court confirmed really what we know, which is kids can't understand the implications of these decisions, that these are experimental therapies, and also they acknowledged what the literature shows, which is, puberty blockers are not a standalone intervention. If a kid goes on a puberty blocker, the likelihood that they'll go on to cross-sex hormones is close to 100%. It's 98, 99%. And so we can't consider, that's another cultural myth out there. There are several, and that's a big one, is that puberty blockers are quote unquote reversible. And by time to decide for that individual, that child, to decide whether or not, or the family, a group decision about whether or not the kid is going to go on to cross-sex hormones, the child. And that's just not reality. The reality is puberty blockers are the first step in this essentially inevitable cascade of interventions. So that was my takeaway, from that ruling. It was that it was a great confirmation and affirmation, to steal that word, of reality, which is.
I'd like to jump in. Like the considered one of the best judges in the UK studied thousands of pages of evidence for this ruling. So it's the first, as far as I would say, massive analysis of it without an agenda. They were judges. They had a team, and they were just trying to analyze, and they sought more evidence, and they continuously sought more evidence and didn't receive it. And then it felt very bizarre when the Tavistock released, almost immediately after the ruling, the evidence that the High Court had sought from them, which was a study that they had started in 2011, that he had apparently finished by 2014. They were analysing the results, and there was a lot of kind of ifs and buts and different things happening. But effectively, they went to go about publishing it within days after the ruling. It feels really murky. And we could go off into that a lot. But to be honest, now that you're in front of me, I'm dying to hear, what does puberty bring us hormonally, and what does the stopping of puberty do hormonally to a person? That's really what's really chiming in my head as something that I'd like to hear you talk about.
Yeah, sure. So the first thing you said is a great point. It's curious, why did that study, why was that essentially published, a day or two after the ruling? And what's interesting is, the study, and it's difficult to even call that a study. It was just basically a description. It didn't ask a clinical question.
There were no experimental variables, right?
Yeah, there was no control group.
Right.
Yeah, it was disappointing because, if they had designed that study appropriately, we could have gotten a lot of really good information from it.
And could I just put in, for anybody who doesn't know, that this is the Tavistock who created this study, that the GIDS, in the Gender Identity Development Service in the UK, which is the largest gender identity development service in the UK, run by the NHS. It's the big boy in the UK who was carrying out this study, and their lack of data was probably one of the many shocking features of it.
Yeah, you're right. This is a well-respected, worldwide known institution clinic that didn't design a study essentially, and it really boggles the mind because, in a sense, it's almost 10 years wasted. We could have had a significant amount of information if they had had a control group to compare these interventions to. And so essentially what they published was just a description of what you would expect of what puberty blockers do. There was nothing really new. Puberty blockers halt the physical development of, stop puberty, and puberty is arguably and is the most significant developmental time for a human.
Wow.
In terms of physical and psychosocial development. It's this integrated process of physical development, sexual maturity, and then as that occurs, that individual has age appropriate psychosocial sexual interactions with peers, and essentially figures out who they are and how they fit into being a human being and fit into their culture, their society, wherever they happen to be at that stage of their life. So it's a profoundly significant developmental process. It's the transition from childhood to adulthood. It couldn't be more important in terms of an individual's long-term physical and mental health. So I can't really overstate the importance of puberty in terms of its impact on humans. And so if you block that process, you don't get physical maturity. So basically growth stops, and the natural process of increasing bone density. So during puberty, humans put on more than 50% of the bone density that they'll ever have during their lifetime. And so if you interfere with that process, as all of your peers put on bone density, and you do not, at the end of a 2-year period of time on puberty blockers, your bone density is 90% lower than your age-matched peers, essentially. So there was nothing really new, and then also the study showed exactly what previous studies have shown, which is that the majority, essentially all but one of the kids went on to cross-sex hormones. So puberty blockers are not standalone; they're essentially the first treatment in this cascade. And then the other was that there were no changes in the psychological well-being of those being treated by puberty blockers. And this is a little bit, perhaps different than would have been found in that Dutch study, but which is the original study I was speaking of that the Endocrine Society
changed the world.
Referenced. Yeah, when they said, okay, now it's puberty blockers are it, and psychotherapy is out, or psychological interventions are out. So basically, the UK descriptive study failed to show that these interventions are really beneficial from a psychological standpoint, that they always lead to cross-sex hormones, and that the physical maturity of that individual is halted. The physical maturation.
I looked at what Michael Laidlaw was saying about puberty, and he seemed to suggest, I'm interested, you might know more, he seemed to suggest that there was an implication, like you said, about bone development and bone density and maybe sex organ development. He said we don't know the implications on sex organ development if you go from puberty to a simulated chemical puberty, as in you don't go in through your own natural biological puberty. Mm-hmm. Instead you pause, and you pause everything. As far as I can see, you pause emotional development, cognitive development, all sorts of sexual development, and the development of maybe their sexual orientation, maybe it's lesbian, gay or bisexuality. And then if you then go from a paused puberty to a simulated puberty, there seems to be implications that that's not the same as a biological puberty. I know these are questions that aren't really answered because there isn't really studies, but I'm interested in your views.
Yeah, no, I think that's a good summary of what puberty blockers do. So traditionally, right, the majority of kids who had childhood onset gender dysphoria, depending upon the study, it's somewhere between 60 to 98%, and the figure that has really been settled on is probably somewhere between 70, 75, 80% of kids who have childhood onset gender dysphoria will have resolution of their gender dysphoria as they enter and pass through puberty. And one of the kind of the biggest, I call it gender clinic folklore things out there, is that if a kid has, an adolescent has gender dysphoria that's been persistent since childhood and worsens at early puberty, that's a sign that there will be no resolution of the gender dysphoria. But there's no data to show that. There's been no studies to show, what percentage of kids desist or have resolution of gender dysphoria at what age. It can occur, it appears, at any point during puberty or even afterwards. And this doesn't even get into the fact that, the predominant presentation now is not childhood onset gender dysphoria, it's adolescent onset. And there have been no studies. There's been one look with Dr. Lisa Littman, right? But there have been no significant a bulk of studies done on this group in terms of desistance and when and why. Just kind of anecdotal clinical observations that there's desistance or detransition at the time of brain maturation in the mid-20s, early to mid-20s. So that's a big misconception, is that, we must halt the pubertal development of a child, because if they have worsening of gender dysphoria in early adolescence, quote unquote, that's a sign that they'll have persistent gender dysphoria. But there's no evidence to show that. That is something that many gender clinicians believe, but if you push them on this, they're unable to provide any convincing data that that's actually the case. And the counter argument to that is, if you have somebody with gender dysphoria in early puberty, and this is why more study needs to be done. Well, why not intensify psychological support at that time? Why do we have to halt puberty with a medical intervention? Why not get that individual and his or her family into more intensive psychological counseling to help that child through the distress that comes with that may accompany early puberty, especially if a kid has gender dysphoria. And so that's the sort of stuff that needs to be studied and looked at, and it hasn't. And as a consequence, we're still in an experimental phase.
To kind of build upon that important question, you raised a point earlier, Will, about this pattern that sometimes happens where medicine creates some sort of purported solution, and then they offer that cure, and then more and more people want it. And you're talking about something called iatrogenesis, where the cure for a condition can actually create more instances of that condition in the population. So, I think to answer your question of why is psychological support not being offered, it's because this entire explosion of young people demanding trans interventions has been built by the availability of transition. And I've heard in my work with young people, I've heard a client talk about how a metaphor of I'm at the side of the road, I am bleeding, I am in pain, I'm distressed. And the only car to come by with a solution is hey, we can help you. Here's how to fix that. And it's better than no solution.
Yep.
So it's really tricky because once young people have become convinced that they have gender dysphoria, they're experiencing this distress about their body, they're not really seeing any other choices. And so it becomes this reciprocal process of client demand and medicine being more than happy to provide this novel kind of experimental exotic solution.
I think that's exceptionally well put, and really is the reason why interventions need to be studied in the classic scientific method way. You compare interventions to each other. You try to eliminate as many confounding factors as possible. You look at the outcomes, and then you make the best decision that you can. And that's just not been done here. And yes, and so this myth has been perpetuated that the only way to treat gender dysphoria is with medical intervention, and that's another main reason for the organization that's been put together, the SEGM. Because that is a myth. There's no data to support that. So yeah, fully
I
agree.
noticed that Michael Biggs, when he analysed the Tavistock study, he's a professor in Oxford. He pointed out that the reason why Polly Carmichael, who leads the Tavistock, the reason that she gave for running with the puberty blockers was that she was lobbied. She was lobbied by organisations such as Mermaids and Gyres, and she felt pressure from the parents. And there's a really interesting concept arising here, where the client comes in, or the patient comes in to doctors, and says, "I know what I have, and I need you to give me the medication that I've read about on Dr. Google." And I presume you hear a lot about that in your practice in general, Will.
Oh yeah, so that's a great point. This isn't right. This, in a sense, is not a unique situation for clinicians, where someone will come in and say, "I'm convinced that the example for an endocrinologist most typically would be hypothyroidism, so an underactive thyroid. So I'm fatigued and I'm putting on weight, and I've read that it's my thyroid, and basically they're convinced that if they come into the office and get thyroid hormone, a prescription for thyroid hormone, which has some risks. If you are overprescribed thyroid hormone, or you take it when you don't need it.
Can I come in there? My own husband, he put on weight a few years ago, which he's since lost. Well done to him. But when he put on weight, every single one of my friends helpfully suggested, should he get his thyroid checked?
Yes, right.
He should check his supper and his dinner.
Right. Yeah. And for a long time, if you went into a clinician's office requesting thyroid hormone, they might give it to you. But what happened is a study was done, right? The scientific process proceeded as it should. And a study was done showing that if you give thyroid hormone to folks who don't need it or in excess of what they need, their risk of cardiac arrhythmias is essentially tripled. And their risk of bone loss, osteoporosis goes up significantly because the thyroid hormone is indiscriminate. It will burn up body fat, but it also burns up bone as well. And that overstimulation of the cardiac muscle over time increases the risk of cardiac arrhythmias. And so with that information, clinicians were able to say, well, I understand that you're distressed. I'm not saying that you're not, and I'm not discounting what's occurred to you. I'm just saying that if I give you this medication without a clear indication that you need it, I'm likely to do you harm. And based on the code of ethics and medicine, I can't do that. And the FDA actually came out and black boxed thyroid hormone and said, hey, we're aware of this problem that thyroid hormone is being overprescribed. There's now clear evidence that it causes more harm than good, and you should stop doing that. And so most clinicians will not prescribe thyroid hormone when it's indicated, but that means there are some clinics where you can get thyroid hormone if even if you don't need it. That's still occurring, but that's not that often. But that means that clinicians have to stand their ground and say, look, I understand that you want this. There's either no evidence that it will benefit you, or there is evidence that it will harm you.
It sounds incredibly similar to the arc of puberty blockers.
It is, but I actually see something which I think is more insidious going on. So we have talked a little bit about what happens when a patient or a family of a dysphoric child comes in demanding something, and then maybe the clinician is put in this position where they have to kind of appease the patient. But I've actually seen something different happen more often than not, which is really shocking. And the stories I've heard from parents are so unbelievable that unless hundreds of parents had corroborated these stories, I wouldn't believe them. But parents will, especially I see this happening with gender clinics, but even sometimes with regular psychotherapists or school counselors or therapists, will go to the clinician and say, my child is dysphoric, what should we do? And expect that the therapist will provide, a thoughtful, kind of well-rounded, whole person approach. And they are actually told you must halt the puberty as soon as possible. And it's very dangerous not to do something. Yeah. And even when the parents come with data and research and some of the same kind of concerns that any reasonable physician would have, they are actually criticized or belittled or ostracized by the gender doctor or by the psychologist. So not only are professionals supposed to be the ones to think carefully about whether the client demand makes sense, but actually they are pushing and sometimes emotionally manipulating parents into these very extreme, radical medical interventions. And I'm very curious if there's precedent for that in other areas of medicine, Will, because I was really shocked to hear these stories, and I actually did a little bit of investigation about the lobotomy epidemic in the 40s and 50s, and I found some shockingly similar kind of traits of the physicians that were pushing these procedures, but luckily that kind of came and fizzled out relatively quickly. What do you think? Are there other precedents in medicine where doctors are actively kind of pushing their patients in one direction that doesn't have any evidence behind it?
Yeah, it's a great observation. So it's almost comparable. What's playing out in the clinician's office is almost comparable to what happened at the Endocrine Society meeting I attended. So if you ask that same clinician who's saying, "Oh, if you don't stop puberty, this is catastrophic and this is the only intervention. And then you flip over and you're like, well, how about an antibiotic for my cough? The doctor will say, oh, no, that we've looked at this extensively. There is a ton of evidence showing that most of these respiratory symptoms are viral, and we're going to create antibiotic resistance, and you must follow the data and the science when it comes to antibiotics in viral infections. But as soon as you ask, right, and then you ask the same clinician about puberty blockers, it's almost as if their mind has been captured. It's almost like a psychic epidemic that's infected clinicians, where they stop. They're regurgitating somebody else's information, and so what I'm starting to see is, even in the situation where they will say, no, you can't take antibiotics for a viral infection, right? Because antibiotics don't treat viruses, and we don't want to increase antibacterial resistance. They're actually also spouting somebody else's information in that situation.
Oh yeah.
And but it sounds rational because the information they're spouting is actually scientifically based. And so what I'm starting to realize is that probably most of the clinicians in these situations, they're not actually thinking for themselves. Even when it comes to evidence-based medicine, they're just simply reading what the guidelines state. And then what you get from that individual is just what they've been programmed to say. And so if they're programming, the sources of their programming have been affirmation-based, and, all the information that's what you're going to get. And in their mind, it's completely logical because, it's actually no different than what they're doing with the evidence-based advice they're giving. That's also programming as well.
I thought that when you were talking about yourself at that conference in 2017 and how you went off to look at the data and you must have missed some landmark study, I was thinking to myself, I bet you most people thought the exact same thought, and few went and looked for the study, and few had the confidence to realize I keep up to date and this is low evidence and I'm not missing something. Most people are on the back foot. We're all hurried. We presume other people know better, and we presume other people are more diligent and efficient. And so they presume, they bit their lip and they thought, I'm missing something, and I don't want to embarrass myself by asking, has the emperor got any clothes on? Yeah.
That's a great point. And I think this gets to a broader issue of how clinicians are trained now, which is and a related topic of unintended consequences. So when you try to elevate the level of practice across, a population, for example, right? You put out guidelines that are supposed to help busy clinicians, right? Mm-hmm. So as you've said, to figure out how to make a good decision in a short period of time, but what
they're just saying, spoon feed me.
Yes. So what you end up with, though, is basically a bunch of programmed robots, for lack of a better word, where they are just regurgitating what the guidelines state. And so there needs to be a fundamental shift. And you see this. I see this more in the UK than there is in the US, in a good way. In the UK, they're much more skeptical, and that's been one of the advantages of this international collaboration in SEGM is, the UK clinicians, they're very skeptical of guidelines. So there's, who wrote those guidelines? Well, were there any conflicts of interest? And the conflicts of interest regulations are much stricter in the UK. Well, who wrote those guidelines? Well, this is rubbish. We're not going to follow this. And to my ears, this is music. This is wonderful, right? Because we almost never hear that in the United States. It's, well, the guidelines say this, the guidelines say this, et cetera, et cetera. And so, I think it comes out of a a good place, which is, well, if we put some smart people in charge of these organizations who then put out guidelines, we're going to elevate overall the quality of medicine that's provided and really minimize antibiotic resistance, because now pediatricians are just not prescribing amoxicillin for every kid with a cough now, right?
Yeah, but there's a galactic difference between the health service in America and the health service in England, because the health service in England is free. And the health service in America, people can make an awful lot of money by saying yes. And I say this from Ireland, where we've got this semi-private situation. So we've got a bit of both, if you follow me.
Yeah.
But I think it's no accident that it's the NHS, who are a free service, who've come out with the lack, where all the endocrinologists won't make the money and all the surgeons won't make the money with their new guidelines, because their new guidelines are going for a slower, more evidence-based approach.
Yeah, I think that's a good point. I think many intersecting issues here, right? So there are some clinics, for example, that some hospitals in the United States, most clinicians are employed by hospitals now, a large majority, where they have contracts with hospitals where you're just paid a flat salary, and there are others where you're paid for the interventions that you perform and the work that you do and the number of patients that you see, and it provides an incentive that could be misaligned with the ethical practice of evidence-based medicine, for sure. It's I think as well, though, I mean, it's a great point. I'm not sure I have a clean answer as to how to undo this, but certainly my own observations of my own colleagues and having experienced the educational process to becoming, an MD, it's not, it doesn't select for critical thinkers. And so I think that's part of the problem as well. And I think that's a harsh reality that we're going to have to come to face at some point.
I'm aware that there's also a perception, I think, here in the US, that if you question the major current established guidelines for any medical practice, that you're some kind of conspiracy theorist, or you're like an anti-vaxxer. And I remember speaking with a family whose child was gender dysphoric, and they had just started researching the topic. And by the time they contacted me, they very much had suspicions about the affirmative model. But they said, when we first started looking into this, we thought everybody against this idea was like an anti-vaxxer. Mm-hmm. So it's very interesting to me how, though the guidelines around childhood dysphoria have changed so radically, so fast, the public perception is that, well, if AMA says it, if Endocrine Society says it, it must be really well-established, well-documented evidence.
Right.
And, to combine that with the way, unfortunately, some, medical school students and residents are just perhaps lacking the initiative to take a look for themselves and just make sure that what they're learning is correct. I mean, who does that? Like, who goes to medical school and fact checks everything?
Who does?
You've got to, right? You're yes, there's this, right, the sense that the folks in authority have everyone's best interest at heart, et cetera, et cetera. It's really interesting. I mean, the other thing at play here is, if you notice something that the rest of the herd is not going along with, or you notice something that the herd is wrong about the way the herd is moving, right? And you start to notice that the pressure from the herd back towards you to get back in line is immense and stressful, and so there's an immense amount of pressure to not create a problem for yourself, and it's easier to say, oh, well, I'm going to defer to the experts. I'm just going to sit this one out, because when you raise your hand and you start asking questions, you start to get a lot of attention, and a lot of that can be negative attention from folks who may have an interest to prevent your point of view from, having having some light shown on it.
Well, I mean, I think there is this obviously pressure in the US, and it has, of course, existed elsewhere too. But I'm aware that, like with many kind of dark moments in medical history where something is widely adopted that is unsafe, and then things start to turn a corner, it really feels like that's where we are now post, this UK ruling. So before we let you go, Will, can you just give us an impression of how you think other responsible countries have responded to the UK ruling? Because I see a lot of countries pulling back.
Mm-hmm. Yeah, I think that's a good point. So kind of getting back to why the scientific method matters is you want high quality evidence to guide your interventions, because you'll be less likely to make a mistake. And so if low quality evidence is guiding interventions, or no evidence, and it's essentially experimental, mistakes are going to happen and people are going to be harmed. And so that's what happened with the Kiera case, right? So she came forward and said, I was harmed for the following reasons, and that generated this review, which basically, confirmed, yes, that's what indeed happened, and that in and of itself is tragic. Doctors know this, though, that if you intervene when there's no evidence, there's likely to be harm. And so that's what's occurring. And so as people are being harmed by this approach, and they start to speak up and they come forward with evidence of that harm, eventually, reasonable people will start to see that and say, hey, we got to take a look at this. There's something not right here. Why is this harm occurring? Perhaps our guidelines and our recommendations are not correct. And so that's what's starting to happen, and it's kind of happening together in multiple places. So in Finland, for example, there was a review of evidence, and by the Finnish health authorities. I don't know exactly what their ministries are called, but essentially they came forth and said, there is not clear evidence that medical interventions, puberty blockers, cross-sex hormone surgeries are beneficial for minors. And so psychological support is going to be the first line, is our recommended first line intervention. Sweden, again, they're reviewing the literature and have essentially come to the same conclusion, that there is not strong evidence to support these interventions. We've got the Kiera case, and then also the NHS is independently reviewing the data. There was a statement put out by the Royal College of General Practitioners, I believe, in the UK, 50,000 strong. And essentially they came to the same conclusion. There's not strong data to support these interventions. Caution is warranted. We are in an experimental state here. And so it's good to see this occurring. This is what needs to happen. It is always unfortunate to see why that it has to go this way, where you have to see harm before people start to take notice. That's always been really bothersome to me. If the principles of academic scientific investigation and ethical practice had been followed from the start, these interventions would not have been employed outside of clinical trials, and we wouldn't be in this situation. So, yeah. And then the U.S., we'll have to see what happens in the U.S. The question is, what is the burden of harm that has to be done before people start to take notice?
Mm-hmm. I've noticed, I'm in Ireland, and I've noticed that there has been, we were very administered by the Tavistock, and they were holding monthly clinics over in Ireland from the UK, and that's going to be stopped. And certainly it's already stopped. And there has been a few leading articles from leading physicians, psychiatrists, doctors, just in the last few weeks, all in the wake of the Kiera Bell, that has been a game changer in Ireland. There's no doubt about it. And I would be very surprised to see any puberty blockers prescribed to children in Ireland following this case. So I'm thrilled. I do want to say before we finish that I remember I had my own experience of gender dysphoria as a kid, or certainly what would be described as it. Mm-hmm. And I remember where I was the first day I was told about the concept of puberty blockers, and I just, as a psychotherapist, went, no, psychologically, no, inappropriate. I remember how I felt as a kid. Had I been given the concept of you can stop this, you can stop your body growing, becoming a woman, this feeling of out of control feeling with your body, you can stop it all. There's a pill out there that can stop this. I would have gone through 7 oceans to get it. It been such an intense, I need that pill to stop this crazy shit happening to my body. And I knew it. And as soon as I heard it, just psychologically, puberty blockers are a very, very, very dangerous concept to bring into a child who is undergoing the hardest time of their childhood, the most difficult time, and yet the most appropriate time. Because for thousands of years, there's been rites of passage for children who are moving from childhood to adolescence, because it's a very important time, not only physically, but psychologically, that you're moving into the kind of the weird space between childhood and adulthood. It's a weird space, it's a difficult space, and it's an essential space. So I just think psychologically, puberty is incredibly necessary, and you don't jump in on that without a lot of reason.
Yeah, well said.
Well, Dr. William Malone, we really appreciated having you on today to discuss all of this.
My pleasure. It's great to be here.
Yeah,
thank you.
It was really great. Can you share with our audience where they might find you, and also how to find SEGM?
Yeah, so the best place to find me and information is at the SEGM website. So it's www.segm.org, and we have a lot of information there, and it's growing. And the information there is purposefully applicable to a whole range of folks who have no experience in this topic, want to learn more, or up to clinicians who are interested in what the latest research is showing. And we'll have more and more information on that website with a bibliography so that clinicians and others can access information. And then SEGM also has an active Twitter feed. It's SEGM Tweets. And then I'm on Twitter as well. You can find me there. I think it's Will_Malone. And I also send out information about gender dysphoria and analysis of current events and studies.
Thanks for joining us this week on Gender, a Wider Lens. This podcast is partially sponsored by RIME, Rethink Identity Medicine Ethics. RIME is a nonprofit organization dedicated to improving the long-term care for gender-variant individuals. Visit rethinkime.org to learn more.
If you found value in our show, please review us on iTunes and subscribe so you never miss an episode. And you can follow us on Twitter, Facebook, or Instagram. Just go to our link tree. That's linktr.ee/widerlenspod.
Our discussions are for educational purposes only and are not intended as a substitute for mental health services.